morning. My name is Dr. Thasor Rup Sawang from Cheong. I'm the Chief Director of Hospital Improvement Section. I'm an ENT doctor. Okay, thank you for have a chance to share the experience today. I have met you before, Dr. Eric in Chiang Mai, yes, in the last 2 weeks. Okay, this is my first time to share my experience. Okay. Today I will share my experience regarding the incident that happened to one of our patients. Okay, let's start. The female patient, age 46 years old, okay, admit to the surgery department on bed 29 with the abdominal pain symptom on date 26 June 2023. The patient was diagnosed with acute appendicitis, and the appendectomy was done on the same day on the 9 a.m. Before the surgery, the patient received the antibiotic ceftriaxone 2 grams and metronidazole 500 milligrams intravenous. There is no allergic reaction to the drug and the patient. And after the surgery, the doctor ordered to stop the antibiotic due to the finding in the OR was acute focal appendicitis. On the next day, on date 27, the patient received ceftriaxone 2 grams intravenous on the 6 a.m., which there was no order to inject this medicine to our patient. And 5 minutes after receiving the medicine, the patient has a rash on her body and itching. The nurse realized that she has given the medicine to the wrong person. The nurse takes the medicine from the patient in the opposite bed, the bed 28, and inject it into our patient who is in the bed 29. And after that, the nurse reports the patient's condition to the doctor. The doctor ordered CPM 10 milligram intravenous and notified the pharmacist for evaluate and issue a ceftriaxone allergy card. After receiving the CPM, the itching improved. Okay, this is my case. Thank you for sharing.
Thank you. Thank you for sharing the case. We won't be able to do all the work that we did in Chiang Mai, so we're going to run through some of the case. So what I will do is that I will do case reviews, and then we can have more conversations. Anyone who has any question can also bring it up so that we can talk about it. So be more interactive as much as possible. Those who are in Chiang Mai with me will understand that I like that interaction and questions so that everybody can learn from each other, and I also can learn from you. I think the chronology of event reported was very good. There is a very precise time as to what happened when, who was involved. I think that chronology of event is very well defined in this case. So if you have down and the investigation has come to the level where patients are now in ward, post-surgical ward, I think, right? So next question is, why is it only, so the investigation can proceed further?
Yes, yes.
And go into more precise contributing factor. What was the process of administration?
Yes, I think this is administration error of the
correct.
Yes.
Correct. But what is your policy? What is your SOP?
Yes.
So before we administer a medicine in bed 28, for example,
yes,
what was supposed to be the SOP?
Yes. Okay, I will give you the further information. After we did the RCA, so we find that the nurse that when the nurse go to the bed 20, sorry, I will confuse about the bed.
20.
Okay, so okay, in our patient, okay, 29.
28 is your patient.
Okay, 28. Sorry.
Yeah, 29 is your patient, I think. Yes. Or was it 20? No, 28 is your patient. 29 is another patient. Yeah, 29 is another patient.
Yes.
So your patient is 28.
Yes.
Okay.
My patient is 28, right? Yes. And when the nurse come to the bed 28, it's a time for the bed 29 ask her about the medicine that she gave her before about the inhaler because they have a history about the COPD and asthma. So that the nurse come back to the counter to check about the data of the patient in bed 29.
So
Okay.
patient is 29.
Yes.
Yes. Another patient is 28, correct?
Yes, but
yeah, so your patient is 29.
yes, my patient is 29. The opposite bed is 28 asks her about the information about the last medication about the inhaler of the treatment of the asthma and COPD. So the nurse came back to the counter to check the information about that, and she came back to the bed 29 and inject the ceftriaxone of the 28. So they have no order because the doctor stopped the medication after the surgery. So they after I think she told me she identification of the 28, but she have interrupt with the question. So she came back in the wrong bed, and after that she inject the medicine in the wrong. So that means she not identify again when they want to inject the medicine in the body of the patient. This is the first thing that I know about her.
Do we agree that this is human error? Agree human error, raise your hand. How many? 1, 2, come on, don't be shy. We're all going to be active in this. I'm going to try and stand up. 1, 2, 3.
Me too.
Okay, Ili, I think that you have to walk. Yeah.
Okay, so how many of you think is human error? Agree that it's human error? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Right. So then we confirm it's a human error. Let's just punish the staff. And case closed. No? No? Then what else? What else is wrong? What else do you think is wrong? Anyone want to try? People on online, you can post your comments. If we have time, we can run through your comments also. Anyone in the room wants to try? What else went wrong?
ขออนุญาตกลับไปดูที่สไลด์อะค่ะเพราะว่าสงสัยแต่แรกว่าเคสนี้ทำไมถึงสงสัยเรื่องแพ้ยาอันที่หนึ่งเนาะคืออยากให้อาจารย์กลับไปดูที่สไลด์นิดนึงว่าเดี๋ยวจะขออีกรอบนึงค่ะคือสงสัยว่าทำไมเคสนี้ถึงตัดสินใจว่าเคสนี้แพ้ยา
Why did you consider that this person was allergic to this medication?
ครับจริงๆถ้าเราดูตอนแรกคนไข้ได้รับยาเซฟไตราโซนพรีออเปอเรชันเนาะครับจริงๆเคสนี้ก็คิดกันพอสมควรว่าคนนี้ใช่แพ้ยาไหมเพราะว่าคนไข้ได้รับเซฟไตราโซนพรีออเปอเรชันไป1โดสแล้วก็ไม่มีประวัติดักอัลเลอร์จีซึ่งจริงๆพอไปสัชกร
ขอแปลด้วยค่ะ
ครับ
Because this case has already received ceftriaxone during operations and there was no allergic reactions during that time.
ครับแต่ว่าพอมาได้รับอีก1ครั้งเกิดอาการแพ้ยาก็คือมีแรชแล้วก็มีอาการคันเกิดขึ้น
So the second time when he received an IV, there was a rash that occurred afterwards.
ครับก็เลยการแก้ไขเบื้องต้นก็คือมีการรักษาเหมือนกับการแพ้ไปแล้วก็มีการ notify เภสัชกรรมเพื่อมาประเมินเรื่องของการแพ้ยา
So that's why we give an antidote for the allergic reactions and then notify the pharmacist to manage the case.
Patient could have died if he didn't do what he did.
คำถามคือการให้ครั้งที่1อะค่ะกับครั้งที่2วิธีการให้เหมือนกันไหมหมายถึงว่าเป็น push หรือเป็น IV
คือเซฟไตราโซนที่โรงพยาบาลจะเป็นดริปอยู่แล้วครับเพราะว่าเนื่องจากมันมีประวัติการพุชและเคยแพ้เป็น policy ของโรงพยาบาลว่าจะต้องดริปยาเสมอ
So she asked whether it was a push or IV approach medication administration that was used in the OR. He said it was always stripped because there was a policy in the hospital that they never pushed the antibiotics.
ครับผมก็คือเคสนี้คุยกันเยอะเพราะว่าอย่างที่สงสัยเหมือนอาจารย์เหมือนกันว่าทำไมเพราะว่าครั้งแรกไม่แพ้นะครับก็ เภสัชกรมาประเมินละก็คือใช้สกอร์ของเขาสุดท้ายก็คือว่าคิดว่าเป็นเลทรีแอคชั่นก็คือโดนมีการกระตุ้นของการได้ยาครั้งที่2แล้วเกิดallergic reaction เกิดขึ้นครับก็เลยคิดว่าเป็นการแพ้ยาเซปไทโอโซน
So the pharmacists are already talked quite a lot, and they agree that this kind of late reaction because there's a kind of a second dosage that's been given, so that kind of triggered the allergic reaction for
It's an
the
overdose,
patient.
right? So,
Yes.
okay, so what I want to say is not about. Sometimes when we do investigation, we reached into that part. The case has mentioned down to that the nurse actually made a mistake. And usually we will report that it's a human error that result into medication error, correct? What I want to share today as an example, and thank you for sharing the case, I really, really appreciate it. And we all learn, and we have to please give them a round of applause. Give everybody who gives the case a round of applause. Because without you guys sharing, we don't learn. So here are some of the things that I use when I do this.
In Zoom, 2 or 3 comments that staff got distracted doing a second call, one, and one not asking patient name before administering medication. This is from Rebecca Gaya.
So, correct. There is a non-compliance to your protocol, your administration protocol. Then my question is that, is it always because of distraction that you non-comply? What about double check before administration? It's also part of your protocol. Double check before administration, agree? Yes? Yes? Very basic, simple SOP. My question is, where is the second person when they double check before administration? Then you think one step deeper. Why is it that we don't have the second person on site when the nurse was all alone? One more step deeper. Because we never have enough staff in the ward. One staff take care of 4 ward. 2 staff take care of 10 ward. We never have enough staff. Therefore, we have to do that. Then you dive one more question deep. Why we never have enough staff? And yet, is that the correct way of treating or providing care for our patient in the ward? What did the organization think? So I want you to dive into every section of things. And now that if this one nurse, example, is taking care of 4 wards, for example, is it humanly possible to manage effectively and efficiently? That's the question that we ask. Is it humanly possible to remember and knowing the busy ward, especially post-surgical ward? Everybody is very demanding because I have pain, I'm not comfortable, everybody is making noise in post-surgical ward. Is it reasonable to only have one human or one staff dealing with that number of wards? So we want to dive, so remove ourselves from blaming just the human error. Yes, I told you before, human make the error. The last hand who make the error is always a human. But do you think the nurse purposely make the error? She come to work because she want to create error. That's the job? No. So we want to study more about what has caused this. And next time, for example, if she is distracted, and every time when we have to do administration, should we have that second person? As according to protocol. And you can tell your leadership, if we do not have this, this is an example of causing, maybe next month, another nurse is going to be doing the same error. Do you want more case? If you don't do this, this is evidence and facts. It's a real case. And we say, if we want to learn from this, what should we do? This is what I want you to dive in, to go down to the detail of the investigation and find the contributing factors. Question?
Yeah, my name is Ambika. Another factor that I think is the environment. When the nurse admin the drug, because the staff was interrupted by another person, and the bed management, the area that manage put the bed beside and near, and make the staff confused when they go back, when they was interrupt and do another thing and go back, and so they confuse the bed 28 or 29. So that's why make they have the error that time.
Maybe this is a new staff who is not familiar with where
Yeah.
28 and 29 is.
Yes. Yeah.
Then the next question I ask, what do you do with the new staff? Do you let the new staff do alone? So what is your guideline when we have new staff? Maybe it's a new staff, not familiar with the ward. This is supposed to be 28, this is supposed to be 29 because I knew. Yes, I worked in the old hospital for 20 years, but I'm new into this hospital. I'm not familiar with the numbering of the bed. That can be one. Then in terms of the proximity, I'm not so concerned because every bed is designed with aisles where we can push an emergency cart in. Every bed is designed like that. If your bed is designed too close, I can say shake hand with my neighbor, then something wrong with your design for infection purpose and for safety purpose. If I cannot push my emergency cart into the aisle area of the patient, something wrong with your design.